the online course on neonatal blood transfusion and hematologic disorders. And here in this room, I have a couple of speakers. To my left and to your right, probably Nina Huben, Derek De Winter, and Romy Potov. But there are other people online, and the people that have registered for this course are here listed in the here to the right. Some of these people are probably sleeping, and they're gonna because it's probably nighttime somewhere in Mexico or I don't know, South Korea. So, but welcome to everyone, and those who cannot join now online will probably be able to see it, the recorded version later on. This is the program for today. I will give you a short introduction and objectives of the course this afternoon. And then Stefano Girardello from Pavia is online and will start by giving an important presentation on the use of red blood cell transfusion. So thank you, Stefano. I will give you the word in just a second. Then after Stefano, I will talk about the platelet transfusion. After that, Nina will talk about fresh frozen plasma transfusions. We'll have a short break after these three presentations. And then Derek will kick off again after the break with hemolytic disease of the fetus and neonate. And Romy will end the presentations with a talk on fetal and neonatal alloimmune thrombocytopenia. We can have at the end a discussion, but I think it's maybe nicer to have a small one or two questions after each presentation. That's probably nicer also for the people who have to leave. I might have to leave a little bit earlier than 4:40 because I am on call from 4:30, so we might have to end a little bit earlier. But before I start and give the word to Stefano, if there are any questions, please raise your hand in Zoom. We have a laptop here on the front, and we can see if there are questions from the audience online. And if we don't see the hands, just interrupt us. It's not a problem. But we'll start with Stefano with red blood cell transfusion. So Stefano, the floor is yours.
Thank you very much, Enrico. Thank you to all participants and all colleagues. And I will share my screen. We talk about the red blood cell transfusion. Transfusion of red blood cells is common practice, especially in NICU, especially for critically ill neonates, such as preterm. And up to 90% of extremely low birth weight infants required one or more red blood cell transfusion during the hospitalization. However, we should remember that when delayed cord clamping is routinely performed in NICU, this rate of transfusion could drop to 60–70% in this category of patients. When we talk about very low birth weight, with the birth weight below 1,500 grams, the percentage of those requiring red blood cell transfusion is around 40%. Overall, about 13% of critically ill term neonates required at least one transfusion during admission. But why we need to transfuse these babies? Hemoglobin concentration on every newborn, as all knows, both term and preterm, normally decrease in the first months of life and reach the nadir that is about 10 grams per deciliter between the 6th and the 12th week of life in term neonates. And this low hemoglobin concentration is due to the low production of endogenous EPO, erythropoietin, the short lifespan of red blood cells, that is about 60 days compared to 120 days in adults of adults red blood cells, and the rapid postnatal growth. So the catch-up indeed induce a dilution effect on the hemoglobin secondary to the increased circulating volume. But this physiologic anemia is generally mild and well tolerated by term newborns and generally require no treatment. In preterms newborns, the expected hemoglobin concentration drop is more severe, occurs earlier, and means around 1 month of life or 6 weeks after birth, and lasts for a longer time, up to 3-6 months. Indeed, the physiological factors that causing anemia in term newborns are more pronounced in this category of patients, and in addition, iatrogenic factors, primary blood samplings, and also critical stages such as sepsis or surgery contribute to the anemia of these patients. And a recent study published by Enrico Lopriore showed that the median cumulative iatrogenic blood loss in the first month of life is around from 15 and 13 ml per kilo in the category of extremely low gestational age newborn. And similarly, we have observed in our data that there is a linear correlation between number of transfusion and blood sampling, especially in the first 2 weeks of life. What is the total blood volume of an extreme preterm newborns? When we talk about 28 weeks preterm newborns with a birth weight of 800 and 500 grams, his volemia is about 60 ml. That means 70-80 ml per kilo. That this is a very nice picture. It's a size of a double espresso, an Italian double espresso. Really, it's really a very low quantity of blood, and we should keep in mind that every drop counts when we have blood sampling with these patients. I suggested to read this editorial from Professor Lopriore. It is very nice and well written. Why do we need red blood cell transfusion? Essentially, is to guarantee tissue oxygenation. Tissue oxygenation depends on hemoglobin concentration, the type of hemoglobin, the concentration of 2,3-dephosphoglycerate, and cardiorespiratory function. Among all these factors, hemoglobin is the only determinant we can easily measure, and it's only relevant when we evaluate hemoglobin in a specific clinical context. As a result, the decision to transfuse red blood cells is actually still based on the hemoglobin and hematocrit for that specific clinical setting. When we should transfuse red blood cells, especially in preterm newborns? We have 2 big randomized trials that have been published in 2020 that have improved our knowledge respected to these questions. The European multicenter trial, the ETNO trial, the effect of transfusion thresholds on neurocognitive outcome of extremely low birth weight infants, reported results on the risk of death or major disabilities, that means cognitive deficit, cerebral palsy, or several visual or hearing impairment at 24 months corrected age from 1,030 preterm infants with a birth weight less than 1 kilo, randomized to a liberal high threshold versus a restrictive low threshold red blood cell transfusion. Similarly, in the same year, it has been published the TOP trial, the transfusion of prenatal trial, that aims to compare a restrictive versus a liberal practice for red blood cell transfusion in 1,800 and a little bit more premature newborns, less than 29 weeks gestational age at birth, and with a birth weight less than 1 kilo. The primary outcome was the same, death or major disabilities at 24 months corrected age. Here we have the clinical characteristics of patients enrolled in both studies. And we can observe that except for a higher rate of cesarean delivery in the European trial, the ITNO trial, patients have similar clinical features with a birth weight around 650 grams, gestational age of median gestational age of 26 weeks. And interesting of note, delayed cord clamping in the ITNO trial was performed in about 60% of patients enrolled, compared to 25% in the top trial. Here we can see the different thresholds applied in the ITNO trial and the top trial. In the first one, the authors consider critical every patient with respiratory support. The mean hemoglobin differences between the low and the high threshold in the European trial, the ITNO trial, was 2 grams per deciliter, and the top trial was 1 gram per deciliter. Both studies found that a higher transfusion threshold does not guarantee a better neurodevelopment outcome, nor reduce the risk of death compared to the lower threshold. And moreover, both studies showed no differences for all the secondary outcomes considered, such as necrotizing enterocolitis, retinopathy of prematurity, bronchopulmonary dysplasia, sepsis, EVH. So the authors concluded, both trials concluded that a lower threshold could be safely applied to preterm newborns with gestational age below 30 weeks and with a birth weight below 1,000 grams. And so therefore we can safely implement this lower threshold. And to this respect, we have a recent guideline published in JAMA Open for red blood cell transfusion in very preterm newborns. These guidelines applied the GRADE methodology. Here we can see the developing process. Importantly, parent representative have been included in this process of developing. Here is the PICO questions related to red blood cell transfusion threshold. The population was preterm newborns below 34 weeks, with subgroups that included extremely low gestational age, below 28 weeks, and another subgroup between 29 and 34, and 30 plus 6 days. The intervention was high transfusion threshold, the comparator was low transfusion threshold. And the aim was to compare these two different strategies on a number of short and long-term outcomes that we can see here, survival and the most common and known outcomes of extremely preterm newborns. In this figure, we can see that the first plot summary estimated from the 6th trial included in the meta-analysis. The 6th trial enrolled a total of about 3,500 newborns with a mean gestational age for the extremely low gestational age to 25.9 weeks, and for the other subgroup, 29.8 weeks. We can see that there was no significant difference found in the incidence of survival, BPD, necrotizing enterocolitis, retinopathy of prematurity, severe EVH, and neurodevelopment between the two threshold policy, the high and the low threshold. The quality of evidence was moderate for most of the outcomes, except for periventricular leukomalacia that was low. The quality of evidence was low. Here we can see the transfusional threshold that the authors suggest, depending on postnatal age, the first week of life, the second week of life, and after the third week of life, and the clinical conditions. If patients require respiratory support or not, or eventually a minimal respiratory support. And this is the recommendation by the panel with moderate certainty of evidence. So it means that they give a conditional recommendation. The authors underlined that these recommendations may not apply to patients with acute decompensation or acute bleeding, and suggest that clinicians should consider higher thresholds than those proposed for patients with sepsis, with enterocolitis, with hypertension requiring vasopressor or inotropic support, and patients with previous intrauterine or postnatal exchange transfusion. Additionally, this recommendation may not apply to newborns receiving erythropoiesis-stimulating agents, since this was a condition that was excluded in the trial that has been evaluated in the meta-analysis. Also, this threshold is not applied to congenital cardiac disease patients. Here you can see the results of the European survey carried out by the Neonatal Transfusion Network last year. This figure shows the hemoglobin threshold used for red blood cell transfusion for different postnatal age and respiratory support level. The green bar represents the threshold from the top and the ETNO trial, and there is 5 colors that identifies 5 different clinical scenarios, from the yellow, that means patients in room air, to violet, that are ventilated newborns. Higher hemoglobin thresholds were adopted as the degree of respiratory support increased. Overall, the results showed that around 60% of reported threshold by the responders were above the restrictive threshold from the ETNO and the top trial. And you can see also a substantial variation across centers among the different patient categories. And we hope that this recent guidance, 2024, may contribute in reducing these differences. This is a very important question. Why we are focused on transfusion threshold? Are we doing any harm when we transfused? Probably the answer is yes. There is a biological plausibility for a potential harm of red blood transfusion, also looking at adult literature. When we transfuse, especially preterm new infants, we may induce an hemodynamic stress and cardiac overload, first of all. Immunomodulation has been reported, and also there are many observational studies that found that the red blood cell transfusion is associated with an increase of circulating pro-inflammatory cytokine, heavy metals, oxidative stress indices, and VEGF inhibition. And all these mechanisms may impact on the brain, on the retina, on the lung, on the gut. This is a biological plausibility for the potential harm of red blood cell transfusion. It's interesting, to my opinion, that when we compare the ETNO trial and the top trial, for the main clinical outcome, we can observe that even though patients in the 2 trials have similar characteristics, except for delayed cord clamping, the application of delayed cord clamping, the incidence of death, retinopathy of prematurity, necrotizing enterocolitis, and bronchopulmonary dysplasia were double or even more in patients enrolled in the top trial compared to the ETNO trial. And but we should observe that in the top trial, about 90% of patients enrolled in the low threshold arm were transfused, compared to the 60% in the ETNO trial. So almost double of the patients were transfused in the low threshold arm in the top trial compared to the ETNO trial, and received about 3 times the number of transfusion during hospitalization. So possibly we can imagine that if the patient, it's not a statistical correct approach, but we can imagine that possibly transfusion, heavily transfused patient may have an impact on outcomes. But the impact of red blood cell transfusion does not seem to be only limited to these short-term outcomes. Recently, a number of retrospective analyses from different research groups have shown that an association between red blood cell transfusion exposure and impaired neurodevelopmental outcomes. We should consider that all the studies compare transfused to not transfused patient, so this is relevant as a potential bias, as being transfused implies that a priori condition of sickness. Here we can see the results from our study. There are other studies published after that. Based on our results, we have found that the timing of transfusion and the entity of the exposure may have an impact on cognitive and motor performances both at 2 and 5 years of age, independently from the gestational age, the birth weight, the socioeconomic status, and the comorbidities of these patients. And interestingly, we have found that the higher effect was seen in patients without brain lesions and in those transfused in the first months after birth. If you look at the red box, the impact of a single transfusion, we have considered the impact as negligible. But taking into account that preterm babies are often exposed to multiple transfusions during their hospitalization, the cumulative effect of all these transfusions may have a clinical significant impact. Similarly, here a secondary analysis of the PEANUT trial that came to our similar conclusion. This was a randomized trial that was primarily designed to assess the effect of EPO versus placebo on neurodevelopment in a cohort of about 900 newborns with a gestational age below 29 weeks. The authors concluded that there was no positive effect of high-dose erythropoietin on neurodevelopment, but secondary analysis on more than 600 of preterm newborns enrolled showed that the patients that required red blood cell transfusion had a lower mean cognitive, motor, and language score compared to those that were not transfused. And, to me, it was interesting to see that the impact of a single transfusion evaluated by these authors was similar to that we have found in our retrospective analysis. So, to prevent or reduce red blood cell transfusion should be important for all NICUs, as we have seen that red blood cell transfusion could be harmful. So a blood sparing policy should be implemented in all NICUs, and these policies should include the application of delayed cord clamping whenever possible, especially in preterm newborns. We should remember that umbilical cord milking is not recommended below 28 weeks of gestation, but could be applied after this gestational age in the case delayed cord clamping is not feasible. Erythropoietin administration after the first week of life up to 32 weeks should be considered, as EPO can reduce the need for transfusion. We should perform blood testing only when necessary, and remember that additional blood may be lost after a venipuncture due to blood overdraw. It's quite common in NICU. Blood sample for microbiological testing and blood cell count at NICU admission could be drawn from placenta, and we should consider microtubes to reduce blood volume for testing or alternative use transcutaneous measurement. All these measures should be included in a sparing policy. Which product? Red cells should be compatible with the infant's own blood group and maternal circulating antibodies. In infants less than 4 months of age, whose immunological status is immature, initial pre-transfusion serological testing should be limited to ABO and D typing and to screen it for unexpected red blood cell antibodies using or infant blood or mother's blood. The use of zero of a universal donor type could be considered. The hematocrit of the PEC should be between 50 and 60% and should be stored up to 14 days. Should better to use a CMV cytomegalovirus negative donor up to 1 month corrected age, but leukoreduction is recommended for all infants. Transfusion rate should be no more than 5 ml per kilo per hour. The indication for irradiation change depend on the national committee and the national policy. But theoretically, the best transfusional product is the one most similar to the newborn's red blood cell. That is the product that contain fetal hemoglobin. So the BORN trial is a multicenter double-blind trial that randomized preterm infants below 28 weeks of gestation to receive the cord blood-derived red blood cell, this is to say red blood cell that we collected from placenta of term newborns, and compared to standard care, that is the adult red blood cell. The rationale of this study is to transfuse a product that is more physiologic as it contains mainly fetal hemoglobin instead of adult one. Indeed, fetal hemoglobin has a different dissociation curve, bearing an higher affinity for oxygen and a lower tendency to release oxygen to tissue. And moreover, we know that maintaining a fetal hemoglobin concentration higher than 60% up to 34 weeks of corrected age has been associated with a lower risk of developing retinopathy of prematurity. So the primary endpoint of the BORN trial is to reduce the incidence of death, the composite outcomes of death and retinopathy of prematurity in the treated group. The trial aims to enroll 146 extremely low gestational age newborn, and the recruitment is about to finish, and we expect data analysis by the end of 2024. Here we can see an interim analysis of 58 patients. And on the left, the area under the curve of the hemoglobin, fetal hemoglobin, suggests that fetal hemoglobin, the reduction before 30 weeks of postmenstrual age is critical for severe ROP development. And on the right side, you see that fetal hemoglobin concentration during hospitalization grouped according to the type of red blood products received before 30 weeks of postmenstrual age. If the premise of the study are confirmed, we are facing one of the most important innovation in the field of red blood cell transfusion in neonate. So I'll finish, thank you. And here we have some brief questions. So the first question is, is a low transfusion threshold preferred over a high transfusional threshold for hemoglobin? Yes or no? It's very simple. I expected 100% correct response. We give 30 seconds. I think we can close. The result, oh, probably my English was not well enough. If 12% say no, that high transfusion threshold should be preferred. No, the low transfusion threshold, there is a moderate quality of evidence, should be preferred to high transfusion threshold. The second question in the should red blood cell packs be leukoreduced before being transfused to preterm newborns? We have seen in the last few slides. Yes, correct. The red blood cell should be leukoreduced, absolutely. If compared to adult hemoglobin, fetal hemoglobin has a higher affinity for oxygen, answer A, has a lower affinity for oxygen, B, has a lower tendency to release oxygen to tissue, C, A più C, B più C. We all know that he has a higher affinity for oxygen. And so, consequently, 81% of corrected and 13% almost correct. Has a higher affinity for oxygen, but he has also a lower tendency to release oxygen to tissue. Thank you.
Thank you very much, Stefano. Very nice presentation. We are just we have maybe 1 or 2 minutes for questions before we move to the next one. There were some questions in the chat which we answered already for you. I think Anastasio, if this is good enough, we otherwise just ask again. I have only one question, Stefano. You said the optimal red blood cell product is irradiated red blood cells. This is something that we've been doing also in the Netherlands for many, many years, but we just stopped a couple of years ago because of lack of really robust evidence. So we don't irradiate anymore. I think what we thought we were doing or needed to do was irradiation was to prevent graft versus host disease, correct?
Correct.
And it's
possibly I
theoretically
have
right.
explained. I was maybe I was too fast because I said that irradiation depends on national policy. And leukoreduction is recommended, but irradiation depends on national policy. Indeed, in Italy, in Kenya, Canada, and also maybe in France, is recommended for some categories of patients. But I know we have discussed that in Netherlands, not. And in Italy, the indication is based on the observation that graft versus host disease is, yes, very rare, but it has a 10% mortality. And so based on this observation, but I think that also in Italy, we should recheck and reevaluate this indication. It takes a lot of work. So there are some works that showed that after irradiation, the blood products change and change the oxygen release to tissue after irradiation. So we should, I think in Italy, we should reevaluate this indication for.
Yes, Stefano, there are a couple of more questions. Just to, before we get to the other questions, what is interesting is that Nina, we together with Helen New, have done a survey among blood banks to see what kind of product criteria they all have, and it all varies a lot between the countries. The paper is in progress, so it's not published yet, but I think that's going to be an interesting.
Yeah, but leukoreduction is quite universal, so all do it at least for some neonatal components. But I see a question regarding CMV seronegative components, and that is still a debate, I think, also in literature. We saw that half of the non-establishments in Europe, or the countries at least we included, do provide CMV seronegative components, although the estimated residual risk for transfusion-associated graft versus host disease is estimated in 13 million. So although indeed the chances for, if you already provide CMV leukocyte-reduced components, the additional risks by reduction is quite small by also providing CMV seronegative components. And it's also good to take into account that CMV seronegative components are not always available in all the countries. So for example, it is advised by the UK guideline by Helen Neal, but I spoke to an Indian doctor who said that in their population it's quite hard actually to have a stock of CMV seronegative components. So it also highly depends on the country you're in.
And just to be clear, leucofiltration takes out the white blood cells, and that's where the CMV is. So by doing leucofiltration, you already reduce by a lot the risk of CMV, correct?
Yeah, that's completely correct. So therefore, the additional risk reduction is quite small.
And then there is a question from Mike about, and it's a very interesting point, the increased risk of developmental delay in those with more transfusions could be due to the transfusion, but it could also be due to the fact that those who received more transfusions were sicker and therefore had a higher risk of developmental delay before the transfusion already, just because of the fact that they were sicker. So in the trials, in the TOP and the ETNO trials, there were no difference in between the two groups, the restrictive and liberal, on the long-term outcome. So it's an important point. But to be honest, the difference between the two groups, restrictive versus liberal, was quite, the contrast between the two groups was small. So there was not a lot of difference between the restricted and liberal group. But it's a good question, Mike, and I think there is a correct point. Maybe we're looking at it's probably more complex than only that discussion on transfusion. It's the sicker babies as well.
Absolutely.
Okay, thank you, Stefano.
Thank you.
We will move on to the next presentation and on the platelet transfusion. You're welcome to stay, Stefano, unless
Absolutely.
you're very busy. Let me
Will be a pleasure.
Deze?
Dat denk ik. En dan daarboven inklikken.
Ah, deze?
Ja.
Huh? Oh,
En
ja.
dan daar beneden.
Nee, die moet je schrijven.
Oh.
Ja.
En daar waar staat het? Share screen? Ja?
Klik.
Ja, hier.
Ja.
Oh, okay. I'm 56 years old, so that's why I still have troubles with doing all this click, click, click. So I will talk about platelet transfusions in neonate, and we'll discuss with you, well, it's the new transfusional threshold, but it's actually now getting old because the study this talk is based on is the Planet 2 Matisse study, and it's now already a few years old. But still, not everybody is using this new transfusion threshold, so I think it's still relevant to talk up and to explain why we need to use these new lower restrictive thresholds. So as Stefano already said, we transfuse a lot of blood products in extreme preterm neonates, especially so those below 28 weeks. It's very much so in red blood cell transfusion, but also in platelet transfusion. And why do we transfuse platelets in extreme preterms? Well, the most important criterion or reason why we transfuse them is because we want to prevent a baby to develop a bleeding. And the bleedings in neonates are, of course, mainly intraventricular hemorrhage or lung bleeding. And we are very much afraid of these bleedings in extreme preterm. So when we see low platelets, we tend to react by giving a transfusion to try and avoid these bleedings. Also, because we always learn from the medical schools and that prevention is better than cure. So if you make sure that your platelets are high enough, we always thought, well, then we would avoid having a bleeding. But is it true that platelet transfusions prevent bleeding, and so that transfusions are an advantage for these babies? And this has never really been studied correctly. We always assumed that platelets were like a superhero that would help, but it's might be that these platelets are not so much a superhero, but a Trojan horse, so that they introduce a new problem that we were not aware of in the past. And I will come back to this issue in a short while. And before I move on to the Planis-Matisse trial, just two issues that I think are important to discuss. One is that we see around the world an increase in the use of platelet transfusions over the year. This is especially so in the USA and Canada, where they did this nice survey in where in 20 years' time there was a double or more than a double increase in use of platelet transfusions. But the same group from Marta Sola-Fisner also compared the use of platelet transfusions between Europe and America, and what they saw was something else, was that in America, the thresholds for using platelet transfusion were different than in Europe. Mainly was Germany, Austria, and Switzerland, where the Americans were using much more liberal transfusions, so they were transfusing more platelets with than compared to the European centers. And this, of course, has all to do with legal issues. In America, doctors are probably more afraid that if a baby develops a bleeding, they might be sued by the parents if the baby did not receive a platelet transfusion, because that could have been maybe prevent them from having a bleeding. But what is better, liberal or restrictive transfusion strategy? And finally, after this paper now it's 5 years ago, yes, even longer, the Planet 2 Matisse study in the New England Journal, we know what the answer is to that question. In this study, we tested the hypothesis that a higher transfusion threshold, so 50 for the platelet, would be better than a lower transfusion threshold of 25. And that was the hypothesis. At that time, we thought that that would have been a better strategy to keep the platelets higher than 50. And we did this study in England, and later the Netherlands participated in this study too, in premature infants below 34 weeks with thrombocytopenia below 50 without a recent bleed. And we had a lot of tests that we used, bleeding scores, weekly ultrasound, and also performed a 2-year follow-up in survivors. And the primary outcome in this study was a major bleed or mortality within 28 days of inclusion. And these were the results. These were the first characteristics. As you can see, more or less the same kind of group as in the ETNO and TOP trial that Stefano just discussed. So extreme preterms with a gestational age of 27 weeks and 750 grams. The median postnatal age at randomization, that's an important point, was 1 week or 8 days even. So that was not really at birth. Only 35 to 38% were randomized within the first 5 days of birth. That's because, among others, parents always need time before they can consent to such a difficult study, but also because some of these patients developed thrombocytopenia only after a couple of days or a week. And these were the results. The group with a liberal threshold, now in the light gray, of course, received many more transfusions, especially on day 1 of the study, compared to the group with a lower threshold in the black do you say that?
Bars.
Bars. And that's, of course, the logic. What is not, or what we thought would was not logic at the first, was that what we saw was that the primary outcome was exactly the opposite than what we predicted. We thought that those who had received more transfusion, and because they were in the liberal thresholds, so the red bars here, would have a better outcome than those who received less transfusion. But it was the opposite. It was actually those who received less transfusion in the restricted group that had a better outcome. And this is something that we couldn't understand in the beginning and we did not expect, but it made us think what happened in this trial. Of course, in every study, it's important to admit that there are limitations and strengths, but the limitations were in this study that some of the children already received a transfusion prior to randomization. Some of them already had a bleeding before the randomization. It was not active anymore at the time of randomization, but it was already before. And again, the postnatal age at randomization was 7 to 8 days, whereas we know that most bleeds occur in the first few days of life. So we would have preferred to have a lower age at randomization, but that's the way it went. The strength of these studies, that sensitivity analysis confirmed the primary analysis, and these our results were also confirmed in a systematic review that was done, and it was also confirmed in recent adult studies, such as the PATCH trial, which are due to the time I will not discuss, but we see the same results in adults as in children and in neonates. The same results, meaning that more platelet transfusions could be associated with a worse outcome. So to come back to the question, do transfusion truly prevent bleeding? It looks as if this is not true, and that actually transfusion could even cause bleedings. That's very strange, but let's see what could be the cause behind this strange hypothesis. Well, there are two theories. One is that we give transfusion, a platelet transfusion, at a very high rate of, we give 10 to 20 milliliters per kilo in 30 minutes to an hour, and sometimes even faster than that. And that's for a preterm baby which has vulnerable vessels in the brain, could actually cause a bleeding because of the high speed and the high volume. That's one theory. In another recent randomized trial that was done to see if platelet transfusion were useful in closing the patent ductus arteriosus, the authors saw exactly the same. The group that received more transfusions, so that liberal transfusion group, had a high rate of IVH compared to the group with the more restricted. So this is one theory, and that's why the Planet 3 study, which unfortunately will probably not be done or performed in a near future, but maybe later on. But the Planet 3 study was designed to compare these two different volumes, 5 versus 10 mils per kilo, to see if a lower volume would be better and provoke a less acute increase in intracranial volume of blood. Another theory is that it's not due to the volume, but to the inflammation. Why this theory? Well, because we saw in the Planet 2 Matisse study that another finding was that the babies that received more transfusions had also a higher rate of bronchopulmonary dysplasia. And that's an inflammatory disease of the lungs. This is also something that we did not expect, but one of the theory is that we give platelets, of course, to prevent bleeding, and it helps to helps the clotting. But we know that platelets have also other functions, and one of the functions of platelets is a role in the inflammatory cascade. It has more than a function than only for clotting. So it could be that by giving a transfusion, we provoke a pro-inflammatory reaction. And this is a recent study by the group of Anna Curley that also was the first author in the Planet 2 Matisse trial, where they measured inflammatory reaction before and after platelet transfusion. And they found that after the transfusion, all these, well, I cannot even TGF and CD40, these are all pro-inflammatory cells, are increased after the transfusion. So what are the take-home messages here? We should not underestimate platelets, as we may have used to do in the past, and we should, well, it's not so that it's better be safe than sorry. Maybe it's better not to give a transfusion than to give a transfusion. If you give a transfusion, only do that at the lower thresholds of 25 and not give it too early below 50 if the baby is not actively bleeding. That's the most important message for today. I would like to thank all the collaborators in the Planet Matisse study, the parents, of course, and the families and the neonates that participated, and Suzanne, who was one of the, well, the principal investigators in the studies, Suzanne Fustolo-Gunning, and that's her PhD book here on the right with the title, Not All That Glitters is Gold. And I would also like the people from the Neonatal Transfusion Network. It's a network of European colleagues that, well, we all work together and try to learn more about transfusions. This is the site if you want to read any other things about what this network is doing. Thank you for your attention, and I don't know how quick I was. Nearly on time. Are there any questions in the app? Awaiting Planet 3 studies, would you advise? Okay, so there is a question of Christian Hulsebos from Groningen, Holland. A correct question, especially since the Planet 3 study will not be running. Unfortunately, the group of Anna Curley, who had planned to do the Planet 3 study, is not going to do that in a short while, so we're gonna have to wait a long time. But maybe somebody else would pick up. I would personally advise to give less than more. So I would probably go for the 5 and not give it too quickly. Again, another study from Nina, in which you looked in Europe how quick we would give transfusion, so that some even gave transfusion in 15 minutes.
Yeah.
So that's very, very fast.
Yeah, and I think that is mainly done because of historical considerations, because we're used to give red blood cells over 3 hours, for example, but somehow with platelets we all give them over 30 minutes. But
because they die off, or what's the idea?
Well, the usual, the non-agitation, so you have to, platelets you have to keep them while shaking. You have to, but those limits are often like 8 hours, so there's not such a rush to transfuse them within 30 minutes for this purpose.
So we could give it in an hour.
Yeah, you could, but I think it also could be that neonatologists think that if you give it faster, they faster decrease the risk of bleeding. So I think that also, yeah, take that into account. But yeah, it could be given in a longer period as well.
So, Christian, I hope this answered your question. Probably you have to individualize. If there is a patient with hypotension and an active bleeding, then maybe you could give it quicker. And if the baby is stable and you're just giving it prophylactically and has the baby's normal volemic, then probably you could give it at a lower rate with a lower volume, maybe. It's not nothing is evidence-based in this with this advice. So what would you do, Stefano?
Yeah.
How quick do we do it in Pavia, in Italy?
We have it's some years that I have prolonged the time of transfusion to at least 1 hour for platelet transfusion. Yes, because I've talked about with many transfusionists and specialists in transfusion medicine. They said that clotting. We have taken this suggestion to give fast transfusion from adults, but really there is no sense because clotting is not a risk, and first, and for the baby because there are filters, and so there is no risk of giving. And transfusionists said that 1 to 2 hours is okay, is a good time to give an adequate number of platelets, because the question is that we keep talking about volume while we don't talk about numbers of platelets we give. And so
the higher the volume, the higher the number, but whether it's 10 or 5 mils, it doesn't say much about how much platelets there are in that concentrate.
Exactly. We should improve this knowledge, because we should have a target. So we have platelets below 25,000, and so we wanted to increase by 10,000. So how much volume of that pack I need to give? I think that this is a more tailored approach.
And there is another question. What is your transfusion platelets if you are going to do the threshold to do a spinal fluid puncture? Again, very important question for a lumbar puncture. We usually have a higher threshold of 50, but that is not evidence-based either, but that's probably what everybody, or I think most people use a higher threshold because we are afraid of maybe having a bleed because of that. So for procedures, any kind of procedure, invasive procedure, we usually are more, we want to have a higher threshold. Is that correct for you too, Stefano? Or?
Yes, it's correct. We are all moved by fear, but it's true.
Exactly.
And an interesting study should be to evaluate bleeding time, to give us really the true information of platelet function in that patient. So,
and that's a very nice bridge to the next talk, more or less, because another thing that we give is fresh frozen plasma. And why do we do that? Because we're afraid, of course, of babies bleeding. But is it something that we should do or not? And Nina will give the answer to these questions. Thank you, Nina.
Thank you, Stefano and Erika, for the previous talks. My name is Nina. I'm a PhD candidate in Leiden and at St. Quinn, which is our Dutch national blood bank. And I'm going to talk about fresh frozen plasma, in short FFP. And what is FFP? It's a donor plasma which is frozen shortly after collection, usually within 8 hours, and then stored at very low temperatures. And when it's thawed, it contains near normal levels of many plasma proteins. So this is a common intervention for infants as well. But I want to start with the neonatal hemostatic system because there are actually important differences between neonates compared to adults. So this is the coagulation cascade. As you all know, you have the intrinsic pathway, which is activated to contact activation, and the extrinsic pathway, which is activated to tissue factor. And they come together in a common pathway eventually to form a fibrin clot. However, these coagulation factors, which are part of this cascade, are actually decreased in infants. And during the first 11 weeks of gestation, they don't produce that. They start at 11 weeks. And these also do not cross the placenta, so they don't receive any from their mother. And throughout pregnancy, they have approximately 50% of the activity levels. They increase slightly with the gestational age. So preterm infants have slightly lower activity levels of coagulation factors compared to term infants. And especially vitamin K dependent factors, so 2, 7, 9, and 10 are further reduced in these infants. However, when you do a coagulation assay, and although I know that Stefano is a very big fan of the tech, currently the most commonly used ones are PT and APTT, which are a measure of the intrinsic and extrinsic pathway, respectively. And they are often prolonged in preterm infants or in infants at all at birth because of these lower coagulation factors. And these tests only look at the procoagulant levels. So therefore, if we know that the coagulation levels are lower, we therefore expect that these levels are also prolonged compared to adult results. And one could wonder if these prolonged values actually mean something in these infants. And what we actually suggest in literature is that neonates have a balanced hemostatic system despite these reduced coagulation factors, because this is counterbalanced by a decrease in the national inhibitors of hemostasis. So although their balance is different from what we think is normal compared to adults, we actually think that they have their own balance, which is good for them in that phase of their development. And therefore, it's actually unclear whether prolonged coagulation values actually predict bleeding in this population. And it's really hard to interpret these values in this population because good, validated, and up-to-date reference values are actually lacking. Because it's really hard to actually establish them. We already talked about the fact that infants have a small circulating volume, so many centers do not take some blood and test whether or not these reference values from literature are actually similar to what they find in their own analyzers. However, we do know that those tests are very sensitive for the analyzers and reagents that are used, especially APTT. So that is something you have to take into account. And these values are often also not validated for extreme prematurity below 30 weeks. So it's important to remember that when you think about whether there's a bleeding risk in the infant, you have to consider that this is a multifactorial process, and many other clinical factors influence this process apart from coagulation assays. So this should really be considered when quantifying bleeding risks in infants. Well, then talking about the effectiveness of fresh frozen plasma. So we give fresh frozen plasma with the hope that they can correct these prolonged coagulation assay results and thereby actually reduce the risk of bleeding. And what we see in the evidence that is available is actually that there's inconclusive evidence. So the FFP does not always correct prolonged coagulation assays, and sometimes even not at all. And then the question, can FFP prevent bleeding? Well, there's only been one trial that has been performed. That is 2 years before my birth, so that's quite a long time ago already. And it was done by the NNE trial group, and they randomly assigned just over 750 infants. However, they did not take into account whether these infants had coagulation assay results that were abnormal or prolonged at all. So they didn't check any coagulation assays. And they randomly assigned to FFP or to alternatives. And they looked at short-term outcomes, including IVH, as well as developmental outcomes at 2 years of age. And they did not see any significant differences. So although there are many trials that are performed for the red blood cells and the platelets, for the plasma, such a trial is actually lacking. A current trial recently performed. So we don't know if FFP is actually effectively preventing bleeding, but there are currently no conclusive evidence for this. And as always, transfusion is not without risks. And it's good to emphasize that most transfusions are safe. However, there are still some risks. There are always the risk of mild allergic and febrile reactions, but also to more severe ones such as hemolytic transfusion reactions, as well as transfusion-related acute lung injury, TRALI, or transfusion-associated circulatory overload, which we already discussed a little, known as TACO. However, this population it's quite hard to actually see those transfusion-associated risks because many infants receive multiple interventions at the same time. So therefore, it can also be really hard to distinguish these adverse effects, especially since there are no clear definitions available in this population for transfusion-associated effects. So we expect that actually the transfusion-associated adverse effects are quite underestimated and underreported. And then, following the developmental mismatch I mentioned earlier, we don't know if there are any potential long-term risks. So we know that there's a developmental mismatch between adult donor plasma and neonatal plasma. Infants have higher concentrations of anti-inflammatory factors. And this doesn't necessarily indicate that the neonatal immune system is impaired, but again, rather that they maintain their own balance, adapted to the needs they have in this phase. So it remains unknown whether transfusion with adult plasma may disturb this balance, but this is definitely something we want to know for the future. So what is known about current practice? There has been a systematic review recently that found that 2.5% to 20% of infants are transfused with FFP, and that many of these transfusions are given prophylactically in non-bleeding infants. It's also known that routine coagulation testing leads to increased use of FFP. So if you routinely check whether or not the coagulation test results are normal after birth, it is known that it leads to increased FFP use, which is understandable because, as I explained earlier, we expect that these values are prolonged because of their lower activities of the coagulation factors. And this is also something that came out of a survey across European NICUs that actually found that 11% of NICUs performed routine coagulation testing, and I didn't mention it on the slide, but 36% of NICUs transfuse solely based on prolonged values. So this is really still part of clinical practice now. And then I shortly want to mention a study we performed recently in Europe. So we wanted to describe current practices in a patient level data set. And we ran this study from September 2022 to August 2023. And we had 22 countries participating with a total of 64 NICUs, which were all tertiary level NICUs caring for infants below 32 weeks of gestation. And we included 1,143 preterm infants who were all born below this gestational age limit. And what we actually see, I'm not going to explain all the colors in the graph, but please focus on the orange line. Here you see the cumulative incidence, so that is the proportion of infants that received at least one fresh volume plasma transfusion. And what you see here on the x-axis, we have the days of life. So what we see is that as the curve is steeper during the first days than during the latter days, we see that actually most transfusions are given during the first part of life, and this use decreases over time. So this is also the part in which some centers still perform routine coagulation testing. So we actually expected to see that most FFP transfusions are given during the first days. However, at day 28 of life, approximately 40% of infants received at least one plasma transfusion. So this is actually, I think, quite a significant proportion of infants admitted to the NICU. Well, why do they receive those transfusions? So here you have a pie chart of the primary indication for transfusion. So clinicians could only select one, that's important to mention. And we see that the most common indication for giving plasma is actually active bleeding. However, we see that approximately 1 in 4 transfusions up to nowadays is still given for abnormal coagulation screening results. And we were also surprised to see that 1 in 5 transfusions is actually given for volume replacement and or hypertension. And this is something I haven't discussed before, but I shortly want to touch upon this part of plasma use as well. So yeah, as we saw, 1/5 of FFP transfusions are given for volume replacement or hypertension. However, there's no conclusive evidence supporting the use of plasma over that of other volume replacement options, such as crystal solution. And this is also important to take into account that there are risks associated with FFP transfusions, the ones I mentioned earlier. And it's even hypothesized that plasma transfusion for volume expansion can actually cause pulmonary edema as a result of the increased plasma leakage across the capillary membranes. So this is also another factor when considering to use plasma for volume expansion. So if volume loss can adequately be replaced with other volume replacement options, please do so over plasma because of their potential risks. And then lastly, we already touched about transfusion rates, so the volume and the duration, what should be given. Well, for plasma, we actually don't know. There are no trials available in general actually to guide volume and duration in infants, but also for plasma, such a trial is not available. So what you see here is a graph from our study. On the x-axis, you see the transfusion volume in ml per kilograms, and on the y-axis, you see the duration of transfusions in hours. So we see that the most commonly FFP transfusions for prophylactic transfusions are given in 2 to 3 hours, and usually at a rate of 15, the volume of 15 ml per kilograms. However, also for prophylactic transfusions, we see really fast transfusions, so given in 30 minutes or less. And what we expected is that prophylactic transfusions were given at slower rates compared to those for active bleeding, but actually we didn't see this because these are the transfusions given for active bleeding, and we still see that the most common duration is 2 hours, and the most common transfusion volume is 15 ml per kilograms. So we didn't see that pattern that we expected. But yeah, this is one of the, I think, biggest aspects in transfusion care that needs new advice from future studies. How actually do we give the blood to these infants? I think that was quite short actually, but
very good. Very good.
Yeah, so my main take-home messages are the accurate prediction of bleeding and risk in preterm but also in infants remains a significant challenge, that you have to be mindful of routine coagulation testing in non-bleeding infants because we are expecting that some of these values are prolonged because of their lower activity of the coagulation factors, and that there's no current evidence to support the use of prophylactic FFP in non-bleeding infants with only coagulation assay prolonged values.
Thank you, Nina. It's always good to be mindful, but I would say don't measure coagulation tests in non-bleeding neonates at all, and you will not be, but be mindful.
No, but you are at a place in your career where you can make stronger statements. So definitely listen to Enrico, please.
Thank you again. Were there questions in the chats? If not, I'm sure Stefano wants to spend.
Oh yeah, I didn't mention Stefano. Yeah, because I, as a short bridge to your talk, Stefano, I only explained PT and APT, but Stefano is really intrigued by another coagulation test, which is called PEG. Maybe you want to elaborate shortly on that, Stefano?
You have to unmute yourself, Stefano. Stefano, unmute. And you're still muted. Still muted.
Maybe he's not allowed to unmute.
Okay.
Oh, yes.
Okay. Sorry.
What is TEC? TEC.
We use thromboelastography, that is a test that use whole blood and give a picture of the dynamic of coagulation in a very few minutes. And with this, we have discovered that, as Enrico said, APTT and PT doesn't work and should not be measured, really. Because most of preterm newborns have a normal coagulant profile and evolved in the first month to a procoagulant profile. And it's a very interesting test that from the beginning, in few months, we have seen that we have reduced by 50% the use of FFP. We have got a problem with FFP transfusion in our unit when I work in Milan, and by introducing thromboelastography, and that is a very simple, rapid, and intuitive method to evaluate coagulation. That implies have a look at platelet function and how platelets and coagulation factors works together, because now we talk not about the cascade of factors, but a cell-based model on which where platelets are the center where everything happens. So it's on the platelet surface that the coagulation cascade starts, and there is a burst of thrombin generation. And so without platelets, you can coagulate. Probably with a low level of coagulation factors, you can coagulate if platelet numbers are normal and function are normal. And thromboelastography give a vision of all this model, in vivo model. Okay, not perfect, because we have not tissue factor or others, but a good vision, and that's it. But they joke that the faculty aims to joke with me because I used to talk about thromboelastography, and while Enrico and Nina said, but okay, but it's enough not to test coagulation, to not give FFP.
Yeah, we need more studies, and
Yes.
we have a lot of discussion, and it would be wonderful to have a study using tech and seeing whether fresh frozen plasma in those with abnormal tech has a improved outcome compared to not transfusing them. There are a couple of questions. One is from Dr. Ponti, which I suspect sounds like an Italian name, and it's about the vitamin K after birth. Intramuscular injection. We use intravascular. I'm not sure if whether in Italy how the vitamin K is given. Do you have an Italian protocol for vitamin K?
We use intramuscular injection, but in NICUs, in my and other NICUs, with patients below 1 kilo, we use intravascular vitamin K.
Sorry, Dr. Ponti, you're from Denmark. You can unmute yourself if you want, and maybe I didn't understand your question.
Yeah, it's okay. Yeah, I don't know how low you go from intravascular to intravenous vitamin K. We also look at the birth weight. But actually, my question was if they have coagulation problems, how many times it's reasonable to repeat the vitamin K, maybe as intravascular.
So, but you only know if, so we never measure APTT and PT, very rarely. So we don't know if it's abnormal or not. We just give routinely vitamin K. But do you often measure that in Denmark? Because then you probably, if you have abnormal values, you would need to do something about it. That's the consequence of measuring those things. And then you would have to repeat and give vitamin K extra. And I don't know of any studies saying how often and how much you should then repeat it. So I'm afraid I cannot really answer your question. Is that what you wanted to ask?
Yeah, sure.
If I remember well, in Denmark they did a study in which they gave much more vitamin K than what we used to do in the Netherlands, and now, if I'm correct, we are now adopting that strategy. But that's another discussion. Christian, I don't know if you want to report on that. I know you've asked something else. That's then in term babies with perinatal asphyxia. So that's a different group, but we also apparently measure, I didn't know that, we measure APTT and PT routinely, apparently. I'm not sure we're doing that in our center, but it's apparently a Dutch protocol, so I would have to check on that. But as correctly, what you're saying is, well, should we then or not administer extra vitamin K? If I have to be honest, I don't remember. I think it's very rare for a term baby to have a bleeding, intraventricular bleeding in a term baby is rare, a lung bleeding too. These babies with severe asphyxias sometimes also have very severe thrombocytopenia, so they might have an increased risk of bleeding. I don't know if we should or should not abandon these practices, but I would be reluctant in until we have good studies showing that the management is better if we give fresh frozen plasma. We should probably stop doing routine measurements, I guess. Christian, does that answer your question? You can also unmute yourself. Oh, he agrees. Thankfully. Okay. We have 10 more minutes before we start with the last two talks. So if you want to go to have a quick glass of water or the toilet, we can start again at exactly 3:30. Is that okay? Yeah? We just wait then 10 more minutes and then we start again with Derek on hemolytic disease and then Romy about the autoimmune thrombocytopenia. Thank you for listening until now and hope to see you in 10 minutes. Grazie Stefano.
Ciao.
Sto
Bello.
mangiando cioccolato.
Vedo, vedo. Mi hai fatto anche venire voglia, anch'io ce l'ho in studio il cioccolato.
Te lo posso dare, ma non...
Sta venendo bene, è bello questo corso, poi mi fa piacere.
Grazie.
Hi, everyone.
Oh, hello.
I have a question.
Yes. What is your name?
My name is Leonardo. I work in Neonatal Intensive Care Unit of Padova.
Oh, no, not with Stefano. So Stefano is
No,
Pavia.
no. Padova.
You're in Padova. Yes.
Yeah. So thank you for this webinar. It's very interesting. I was wondering the fetal hemoglobin is better during the fetus life because the placenta has a lower tension in oxygen. But after the birth, in the newborn, is better to have more quantity of in HbA or not?
It's a very interesting question, Leonardo, because so the idea, the hypothesis, is that if we transfuse HbA, it releases oxygen more easily, which could lead to oxygen toxicity, free radicals. So a lot of these diseases, BPD, ROP, NEC maybe, are all inflammatory diseases that could be provoked, among other causes, by a higher oxygen release. So since most transfusions are given in the first weeks, this could probably be better by replacing those transfusions with HbF, so fetal hemoglobin, that would release less quickly that oxygen. That's the idea behind the BORN trial. But you are correct in saying that there might be a stage in which maybe it's better to have more oxygen release. And that's, for example, maybe, theoretically, after 32 weeks, for example, we know for retinopathy has two stages, stage 1 and stage 2. And the stage 2, after 32 weeks, the retina maybe needs more oxygen. So if we are giving HbF after 32 weeks, maybe that's worse. So if I understood well, in the BORN trial in Italy, now they changed the protocol in which before 32 weeks in a group receiving cord blood, they give HbF, and after 32, they give HbA. Primarily due to the fact that we didn't have enough cord blood for all the other children in the transfusion. But for me, it does make sense from a pathological point of view, from a physiological point of view. So it might be that HbF and HbA could be given at different times of life in a different way. But this is all very much hypothesis, and we don't know really what is best.
Very interesting. Thank you very much for the answer.
No problem. Good question. I think it's time to move on to Derek. And Derek is a PhD student who is almost finishing his PhD. Actually, Nina also. They're both, we're going to finish the beginning of next year. And he's doing PhD on hemolytic disease of the fetus and newborn, and he's going to tell us new developments in the management.
Yes, so thank you, Nico, for the introduction. And I'm indeed going to talk about the new developments in the management of HDFN. I'll just abbreviate it from now on. Just as a disclosure from our side, the Dutch research group did receive funding from Janssen, and we are a participating center in the trial that I'm actually going to present today. But before we delve deeper into the new developments of HDFN, it's always good to look back. And the real history of HDFN actually already started with Hippocrates about 400 years before Christ, in which he described a fetus carnosus, which is what we now know as a case with hydrops fetalis. And it was only 2,000 years later that the next report was published by a French midwife, Louise Bourgeois, if I pronounce it correctly. And 300 years after that, there were several reports of universal edema of the fetus, fetal leukemia, an unusual blood-forming spot in the liver, and a familial incidence of the disease. And there was a review in 1932 that actually linked all those reports together, but there was still no understanding of the exact pathophysiology. And that understanding only happened when the rhesus antigen was discovered in the 1940s. And after that, the research in HDFN actually skyrocketed with multiple developments to identify alloimmunized pregnancies. The first replacement transfusion, which is now called an exchange transfusion, happened in 1946. And in 1958, the first publication on artificial light treatment was published. Then we also have rhesus immunoprophylaxis to prevent alloimmunization in pregnancies. We have the first intrauterine transfusions in 1961. And in 1968, the efficacy of phototherapy was proven. And from what I understood from Christian, who's also in this webinar, is that Europe and Brazil were one of the first countries to actually implement phototherapy, and that the Americans took their time to implement it. But eventually, everyone now knows that it's the cornerstone of treating hyperbilirubinemia. And then in 2000, we also have a non-invasive way to detect cases with fetal anemia. And that all those developments that skyrocketed after 1940 actually led to our current understanding of HDFN. And as you may know, it starts with the maternal red blood cell alloantibodies that are directed against the blood group antigen of the fetus, which may be, for example, anti-D, but it could also be anti-Cal, anti-small c, and many others. And those IgG antibodies are actively transported across the placenta by FcRn, and there they may bind to the antigen-positive fetal red blood cells. And on the one hand, that may lead to an inhibition of erythropoiesis, for example, in the case of anti-Cal, but in most cases it will lead to hemolysis. And taken together, that may lead to fetal anemia. And if that is left untreated, that will develop further into hydrops fetalis and later on into perinatal death. If the fetus survives, though, the IgG is still present in the neonatal circulation and thereby also causing hemolysis on the one hand. That may lead to an increase in bilirubin, which may cause icterus, and if that is left untreated, that could lead to Cairn icterus. And on the other hand, there's also an inhibition of erythropoiesis, for example, due to the antenatal treatments that we may provide, and that could lead to neonatal anemia. And with this pathophysiology, there have been numerous amounts of treatments implemented, for example, IVIG or plasmapheresis to the mother, IUTs to the fetus, phototherapy, IVIG, exchange transfusions to the neonate, and also erythropoietin or red blood cell transfusions to treat anemia. So there are numerous treatment options available in this disease. And I just showed you the entire timeline and the pathophysiology, and I'd like to now cover two new developments, of which the first one is the lessons that we learned from the dialysis study, and then lastly, the developments of an FcRn blocker or the UNITY trial. And I'd first like to focus on the dialysis study. We are presenting here from this tiny room in the Netherlands, and we're also in a tiny country, but due to, well, it's actually an advantage that we live in the Netherlands because we have the care for HDFN centralized between Sanquin that performs the serological monitoring and LUC, which we are here right now, to actually treat alloimmunized pregnancies. So we rather well know what's actually happening within our own borders. We don't really know what's happening outside of our borders, also because it's a rare disease. And that's why we work together with 22 other countries and 30 other centers within the dialysis study, which is a creative acronym for Worldwide Collaboration for HDFN. And this study had two overall aims, of which first aim was to describe practice variations in the antenatal and postnatal management of HDFN and describe the clinical outcomes of those affected. And secondly, to identify opportunities to improve care in this rare disease. And that was split into the antenatal phase and postnatal phase. We have been able to ask or answer many questions, but for the sake of this presentation, I'd like to focus on three specific questions, namely, what was the gestational age at birth, what is the frequency of postnatal treatment options, and what is the effect of gestational age at birth on the frequency of exchange transfusions. So in terms of methods, this was an international retrospective observational cohort study, and we included cases in a 15-year period. And that included cases that led to fetal demise, live-born cases with antenatal treatment, and live-born cases with only postnatal treatment and no antenatal treatment. And we collected data all the way from obstetric history onto long-term outcome if that was available. And these 31 centers that collaborated gathered or retrieved data from 2,420 inclusions that were split into the three groups that I just explained. And luckily, a minority led to perinatal death, namely 4%, of which mostly due to severe anemia and severe hydrops fetalis. Then the majority were live-born and received antenatal treatment, and a smaller portion was live-born and received only postnatal treatment. Now focusing on the first question, what was the gestational age at birth? The overall gestational age at birth in cases with an intrauterine transfusion was 35.7 weeks, the median, with an IQR just behind there. And if we then have a closer look at these specific centers, you can see that there's a large variation between the centers that are plotted on the x-axis and the gestational age on the y-axis. Just to make it a bit easier, there's a 5 weeks difference between the lowest median and the highest median of centers. So there's a lot of variations between centers. And that's also the same in cases that did not receive antenatal treatment. Also here we have a high variety in gestational age at birth, namely a 4 weeks difference. So we then also focused on the frequency of exchange transfusions, and overall in the entire cohort, just over 20% received at least one exchange transfusion, but again with a very large range. And if we focus on cases with IUT, we can see that the percentage of neonates that received an exchange ranged between 0 and nearly 60%, and that's also consistent in cases without antenatal treatment, reaching from 0% to nearly 80% between centers. So also in exchange transfusions, there's a large variety. We also focused on the frequency of postnatal IVIG, and overall 1 in 4 received postnatal IVIG, and also we saw a large variety between the centers, reaching from 0% to 80% in cases with IUT, and 0 to 100% in cases without antenatal treatment. So there seems to be no consensus in the use of postnatal IVIG for HDFN. So the lessons that we learned was actually that there are considerable variations and in many aspects of actually managing HDFN, and we identified several opportunities to improve care, and those opportunities that we found are to be published hopefully very soon. And with that first development, I'd like to now go into the second development, which is well, very novel, I think, which is the UNITY trial, but that does require some explanation on the neonatal FC receptor, or in short, FcRn. FcRn is namely the sole salvage receptor for maintaining maternal IgG levels. And here you can see a figure of how that actually happens. In normal situations, IgG would be bound to FcRn and be taken up into a recycling endosome, and is then here on the top released back into the circulation, and anything that's not bound is taken up in the lysosome and thereby destroyed. On the other hand, FcRn is also the sole placental transporter for transporting maternal IgG to the fetal circulation, and that's also done by FcRn, which binds IgG and then releases it back into the fetal circulation, and anything that's not bound is then taken up in a lysosome. And the pharmaceutical company actually developed nipocalimab, which blocks FcRn, and by blocking FcRn, they are able to substantially decrease maternal IgG levels by blocking the IgG or the FcRn-dependent IgG recycling, but also preventing the maternal-fetal transport of IgG. So theoretically, they could prevent HDFN by providing mothers nipocalimab and ensuring that the IgG does not reach the fetus and cannot cause any hemolysis. And that was actually approached in a phase 2 trial that was recently published in the New England Journal of Medicine. And this phase 2 trial included participants with a history of very severe red cell aluminization who were now pregnant with a singleton. These were cases with anti-D or anti-Cal. And the primary outcome was live birth after 32 weeks without an IUT. And they also looked at a few safety outcomes, namely maternal infections, maternal low albumin levels, and infections in neonates and infants. And what they did was that they enrolled patients and provided weekly intravenous nipocalimab starting at 14 weeks until 36 weeks of gestation, and then delivery was planned at 37 weeks or earlier, of course, if indicated. And IVIG was administered to the patients a few days before delivery to hopefully provide some IgG to the infant. And the trial included 13 pregnancies, of which 12 resulted in a live-born infant. There was namely 1 fetal loss owing to complications of the IUT. In terms of baseline characteristics, these are the baseline characteristics of the most recent qualifying pregnancies. So the previous pregnancy, and you can see that there was a very low survival rate of about 40%. The gestational age of delivery was very low. That included the cases that were stillborn. The rate of fetal hydrops was very high, and the median gestational age at first IUT was very low. And this was parts of the results that were published, namely the pharmacodynamics. And what they've shown is that providing nipocalimab to the mother actually decreased their IgG levels by about 85% compared to baseline. And as you can see, once you stop it right here, it again rises. And it's also good to mention that 6 in 10 neonates had a low IgG levels. So that also emphasizes that nipocalimab seems to work in terms of decreasing IgG. Jumping straight to the primary endpoint, of the qualifying pregnancies, 0 fulfilled the criteria for the primary outcome. And in the study pregnancies, so the cases that were administered nipocalimab, just over 50% reached the primary outcome of live birth at 32 weeks without an IUT. They also found that fewer cases required any IUTs, and also the median gestational age at the first IUT was 7 weeks later compared to the qualifying pregnancies, and there were no cases with fetal hydrops. And also the live birth weight was higher, and the gestational age at delivery was higher, and fewer cases required a red blood cell transfusion, and there was only one case that required an exchange transfusion directly after birth. In terms of safety outcomes, they found that 5 in 13 participants had any adverse events of special interest, and those were cases with infections only, but none were deemed to be unusual illnesses. It was mainly lower urinary tract infections in those maternal participants, and in the neonates, 4 in 12 participants had infections or decreased IgG, but again, no unusual infections were found in these infants. So the conclusion of this paper was that nipocalimab delayed or prevented fetal anemia in pregnancies at high risk for early onset severe HDFN. But there is still data required before we can actually implement it into practice. We namely need to assess the efficacy in a larger randomized population. We need more pharmacological data on whether, for example, the fetus or neonate is actually exposed to nipocalimab and what their interaction is to the neonate. And there's also follow-up data required to assess the passive immunity. So, for example, vaccination response in the infant. And that's all to be assessed in a phase 3 trial that's currently going on and was recently published in the American Journal of Perinatology. At least the study protocol was published there, so you can read up all about that. And those were, of course, not the only 2 developments, but the only developments that I spoke about, but there were many more that we have not been able to discuss. And with that, I'd like to give the floor back to you.
Thank you, Derek. Thank you for this presentation. Let me see, are there questions in the chat? Otherwise, I was very curious to know if there are people in the call now that use IVIG in these babies with HDFN. Do you give that to routinely or to prevent exchange transfusion? It's still a topic of discussion. If I remember well, 1/4 of the centers gave IVIG or more.
Yeah, it was 1 in 4 neonates actually received it, but
yeah.
just over half of centers provided
Okay. Yeah.
IVIG.
So 50%, so it's a really a 50-50. I don't know if, Stefano, do you use that in Italy? Only in cases where the bilirubin reaches a high level, or not at all, or? You're muted, Stefano.
We use sometimes when bilirubin is almost at the level of exchange transfusion, just in really few cases.
Yeah.
Because
and
very
in
low
our country, in our country, in the Netherlands, Christian Hulsebos, who is also in the call, revised our Dutch guideline together with his colleagues in Groningen, where they have a lot of experience, and we actually don't do it. We don't give it anymore, if I'm correct, Christian. But it's really not very clear yet, not if it is or not advisable to give it. The studies that have been done until now were performed using IVIG at birth, so prophylactically, not in the group in which the bilirubin was already reaching very high levels. But in that case, we don't know whether it does or does not help. So it's, I guess, not wrong giving it, but we don't know what the effect is. We were afraid that maybe IVIG could have side effects, because there were reports of babies, for example, having necrotizing enterocolitis after IVIG, But in the Dionysus study, Derek, we saw none of them, and there were hundreds of babies receiving IVIG, so that's an interesting finding too. So I don't think we should be too afraid of that. The question is it beneficial or not? That we don't know. Okay, if there are no questions, we can move on to the last presentation by Romy on another autoimmune disease. And Romy is also a PhD student. She just started last year, so she will stay longer with us, and she will discuss an autoimmune disease causing thrombocytopenia. We call it FNAIT.
Yes, thank you, Enrico, for thank you for the introduction. Yes, my name is Romy, and I'm a little bit the outsider here because I'm a PhD candidate from the Obstetrics and Gynecology department. And today I will tell you something about fetal and neonatal autoimmune thrombocytopenia, or in short, FNAIT. But what is FNAIT? Just like HDFN, there is a mismatch between the blood group of the mother and the fetus, but in contrast to HDFN, there is a mismatch between platelets. Because on the membrane of those platelets, there are different types of HPAs, and if they are not corresponding with each other, there could be a mismatch. And during pregnancy, the platelets of the fetus can come into the maternal circulation, where they come in contact with the immune system of the mother. And because of this contact and the mismatch between those blood groups of the HPAs, the human platelet antigens, the mother can form antibodies, and these can cross the placenta into the fetal circulation, where they can bind those fetal platelets and can cause phagocytosis of those platelets. Because the platelets are destroyed, this can result in a thrombocytopenia with a higher bleeding risk in the fetus or shortly after birth. So if we dive deeper into the pathophysiology of FNAIT, I already told you there's an incompatibility between those human platelet antigens. I simplified it here with this picture. If you're HPA, for example, HPA-1a positive, you have those blue dots on the membrane of the platelet, and if you're HPA-1a negative, you miss those blue dots, and thereby you can recognize those fetal platelets as foreign, and the mother is able to mount an autoimmune response. Well, in 80% of the cases, it involves anti-HPA-1a, followed by 10 till 50% of the cases where antibodies against HPA-5b are responsible for FNAIT. And as I already said, it will result in destruction of the fetal platelets, but also in suppression of the platelet production. But furthermore, we found also that those antibodies can also bind to endothelial cells, which will result in even a higher bleeding risk in the fetus. They can also bind to the syncytial trophoblast cells of the placenta, and thereby cause placental dysfunction. And we believe that it can even result in a reduced birth weight and prematurity in those newborns. Moreover, we found a correlation between HPA-1a and the HLA-DRB3 molecule, because we found that women who are HPA-1a negative and also positive for this HLA molecule, so the two pieces of the puzzle, if you have both pieces, you're able to mount a very strong autoimmune response, and thereby can cause a very severe FNAIT. So you need both of those two molecules. And if you're only HPA-1a negative and you don't have the HLA molecule, we often don't see an autoimmune response. So it's important that you have both factors. And in contrast to HDFN, the first pregnancy is often affected, and in HDFN, we mostly see an autoimmune response in the second pregnancy. So the consequences, because of the fetal platelet destruction, this will result in a thrombocytopenia and a higher bleeding risk in the fetus and newborn. And FNAIT can have a very severe course with intracranial hemorrhages, which can lead to neurodevelopmental impairment in 60% of the cases, but also in mortality in 44 of the cases. Organ bleedings, we see that in 12% of the FNAIT cases, with even a higher mortality rate of 67%. But there are also mild bleeding complications, for example, skin manifestations such as hematomas and petechia. How do we diagnose FNAIT? Well, if we diagnose it in the first pregnancy, it's often too late, because then we diagnose, for example, a brain bleed already with the ultrasound, and then only postnatal treatment is possible. But we can also diagnose FNAIT just after birth if we see a neonate with a low platelet count, or if we see some bruises or even intracranial hemorrhages after birth with the cranial ultrasound. But if we diagnose it in the first pregnancy, we can follow up the subsequent pregnancies with the antibody levels, and we can even administer antenatal treatment to those women during pregnancy, which I will tell you later on. And if we suspect a case of FNAIT, we can type the mother, the father, and the fetus for HbA, because as I already said, there are a lot of different HbAs, and we would like to know which type the mother is. And then we can follow up with antibody screening. And also, if the mother is HbA1a negative, we would like to know the HLA-DRB3 status, because as I already said, you need both pieces of the puzzle in case of HbA1a. How do we diagnose it antenatally? Well, you see here the normal anatomy of the brain of the fetus, and we can see with the ultrasound, for example, ventriculomegaly as a consequence of a brain bleed. You see that the ventricles of the fetus are larger than in a normal situation, and here are the real images from an ultrasound prenatal. And you see that the ventricles are much larger than it should. Then postnatally, we can find a low platelet count as an incident finding, but we can also see some hematomas or petechia just after birth. And even in the severe cases, we can detect some organ bleedings, for example, in the lung, but also intracranial hemorrhages or other brain bleeds if we perform a cranial ultrasound on the newborn. Well, FNAIT is a very rare disease, but it can have very severe consequences. But only 2% of the women are HbA1 negative, and of those women, only 10% are able to develop HbA1a antibodies because they have that HLA molecule. Luckily, only 30% of these cases end up in severe FNAIT, and only 10% of those will end up with a brain bleed and intracranial hemorrhage. So it is very rare, but it doesn't mean that it's not important. Here in the Netherlands, we identified 3 different risk groups for FNAIT pregnancies. The first group is an undefined risk group. These are women with no FNAIT in their obstetric history, but they have a possible risk due to screening or family history. There is currently no screening in the Netherlands or in any other country, but you can imagine if we screen those women for HbA1a, and we find that she has a higher risk and it's her first pregnancy, she has not a defined risk yet, and we cannot say if, for example, she has a high risk of developing an ICH in the fetus, because we know, for example, with a high risk group, that if you have a previous pregnancy with FNAIT in your history and an ICH, the recurrence rate for an ICH in the subsequent pregnancy is very high. Then we have also a standard risk category. These are the women that had a previous pregnancy with FNAIT, but without ICH in their obstetric history. So what can we do during pregnancy? Previously, we administered intrauterine platelet transfusions to the fetus if the platelet count was really low. But you can imagine that if the platelet count is really low and we stick a needle into a fetus prone to bleeding, it could have very severe consequences, for example, fetal death. So we stopped with the intrauterine platelet transfusions, also because we have a very effective antenatal treatment, which is IVIG. We can administer this to these women during pregnancy via infusion, and we have a wonderful system here in the Netherlands with sanguine, where the first gift is given in the hospital to see if the woman could have an allergic reaction to the IVIG. But after that, there's a home service where the nurse can come to the house of those women and give a weekly intravenous immunoglobulin infusion. And we see that it's very effective because in 99% of the cases, it's effective in preventing ICH. And the hypothesis behind this working mechanism is that it competes with those HPA-1a antibodies, and thereby there's less transport across the placenta to the fetus, and the antibody titer of the mother will be decreased, and thereby there's less platelet destruction in the fetus. But because there's not yet a screening program, treatment is only possible in a subsequent pregnancy. Then the mode of delivery, because there's still no consensus about how these women should deliver. Often a cesarean section is planned based on the belief that the vaginal delivery could trigger the development of an ICH, but there are considerable variations in guidelines all over the world. But we have consensus that it should be a planned delivery because we could already order some HbA-matched platelets in case the neonate needs a transfusion, and a whole team could stand by for the delivery. But the mode of delivery is also depending on the risk group, the antibody titer, the previous pregnancy of these women, and also patient preferences. Also important to take into account is if these women had IVIG treatment, because we believe that the fetus is somehow protected by IVIG, and we also aim here in the Netherlands for vaginal delivery as long as it is atraumatic. So no use of forceps, vacuum devices, or other instruments could have a risk for bleeding of the neonates. Then the postnatal management, we would like to know the platelet count as soon as possible out of cord blood, and the neonates admitted to the neonatology ward for observation. A platelet transfusion is necessary if the platelet count is lower than 25, as Enrico already told us earlier on, or if the platelet count is lower than 15 and we already detected a bleeding in the neonate. We would like to have HbA-matched platelets for the transfusion, but it's very important that the transfusion is as soon as possible. So if there are no matched platelets available, random transfusion is also good to administer to the neonates. We would like to have a cranial ultrasound performed before 24 hours after birth to see if there are any signs of bleeding or brain bleed in the neonate. But if the platelet count has normalized and the neonate is stable, it is discharged home and no further checkups are necessary. Then the outcomes of these children, because a large study in the Netherlands performed by our colleague Thijs de Vos, the HIP study showed that the neonates that are born from these HbA1a immunized women are more often born preterm, have a lower birth weight, and they are more often admitted to the neonatology ward. And we also saw that the immunization was associated with hypertensive pregnancy disorders. So we really think there is more behind those antibodies doing something with the placenta or the other way around. So we're still doing some research to find this out. And as I already said, there's no screening yet here in the Netherlands, although it could be very effective in identifying the patients at risk. especially for those who are pregnant with their first child. And it could reduce the mortality, morbidity, and also the healthcare costs due to FNAIT. But it's important to keep in mind that with the screening we find a larger group of women who have an undefined risk because they often it's their first pregnancy. So there should be consensus on both the antenatal and postnatal treatment for these children and these pregnancies. And therefore it's very important to have strict guidelines all over the world. So that's something to aim for. And this was FNAIT. Thank you very much.
Thank you very much, Romy, for this beautiful presentation. And we are also right on time. So we have time for questions. Maybe we can join the two talks and ask Derek whether nipocalimab is an option for your disease.
Theoretically, yes.
Yeah.
But as Salome already stated, it's difficult to identify pregnancies or women in their first pregnancy with an immunization, and those are probably the ones you would also like to treat.
Yeah.
But it could, for example, replace IVIG if it is, of course, effective.
Yeah.
It's an option for any alloimmune disease, probably, but the diseases are different and the population is. Yeah. Are there questions from the audience for Derek or for Romy on these two alloimmune disease, or Nina or Stefan are still on the call, so you can also ask them if you have any questions. Or put it on the chat, but I don't see. If not, oh, sorry. There are some ideas on screening for FNAIT. What would you advise? I think that's a good question for Romy.
Yeah, well, I'm a pro screening. I think it would benefit those women. But I would only screen for HbA1c because it involves 80% of the cases. And we could do it as, we're already doing with the NIPT here in the Netherlands. So you just take 1 drop of blood, it could be the same blood, and then you could test the HbA status very quickly. And then you already identify a whole patient group at risk. So I don't think it's very complicated to implement, but you also have to outweigh the risks against the benefit because it will cost a lot of money, and some women wouldn't even make an autoimmune response or make antibodies. So will you take the risk of all the money for the implementation against the few cases you find?
It seems as if the Ministry of Health in the Netherlands is really now seriously envisaging doing this screening in the Netherlands, correct?
Yes, they are considering that advisement.
And as you rightly said, that's for HbA1, because in the 5b there is still a bit of controversy whether the severity, the consequences for the babies are as we know for the HbA1a that these babies are really at risk of bleeding, but in 5b not everybody is that convinced, correct?
Yeah, exactly. We see a lot of women which were immunized with HbA5b, but they don't. There are not any consequences for the baby, so there's no bleeding, no thrombocytopenia. So we are really looking what happens there because there are antibodies, but they're not very effective, you could say.
Thank you. And then there is a question about the cutoff for platelet transfusions, and I think that's for my talk in infants with sepsis or NEC. So from the Planet 2 trial, we saw that the cutoff for these babies, if they are not actively bleeding, because those were not included in the study, was actually 25. So we don't have a different cutoff for babies with sepsis or NEC. We use a lower threshold also in babies with sepsis and NEC. So there is not a the only group where we use a cutoff of 50 is the babies with active bleeding. So it's different than in the thresholds for hemoglobin transfusions, where we have this critically ill and non-critically ill, where in platelet transfusion we only use the discrimination between actively bleeding or not actively bleeding. We don't take into account how ill they are, sepsis, neck, respiratory failure, etc.
So what would you do in an infant with neck and rectal bleeding?
That's an interesting. So that could be considered as an active bleeding. So that would mean that you could use the 50 as a cutoff. Although a rectal bleed, you can sometimes find a little spot of blood, or sometimes it's a large bleed. So that makes also a difference. But in theory, so that would be an active bleed. But that's a definition issue. Yeah. Good questions. If there are no more questions, I want to thank you very much for listening. Thank the speakers for the nice presentation. And I hope to see you next year for another update. And maybe we will have some new results from other studies about the studies that we're performing. Thank you all very much and have a good evening. And thank you again.
Thank you very much, Enrico. Bye to
Bye-bye.
all. Bye.
Ciao.
Ciao.